I'm Dr Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery in Sydney, and welcome to this video on keratoconus key summary points. Why is that important? Because there's a lot of crap in keratoconus, and having some key summary points is really useful. So this video is about key summary points. They're not my key summary points. They're published in Corneal Journal back in 2015, and they're just as relevant today. Whatever you hear in keratoconus, all the papers that come out and all the crap that comes out, and I've reviewed some papers and had to reject them because it's all superficially great, no depth. You're walking in a kiddie's pool with little splashes and they're telling you you're swimming. There's a lot of rubbish. But this article has a great summary and I think it's important to share it. So here we go. It's a long table here that has their summary parameters. And the top of it says agreements reached in the definition diagnosis panel. That's very important. Everyone getting together saying, what is an agreement? How do we agree on certain things? Too small there, so I'm going to magnify it and go through it bit by bit. The first one says the following findings are mandatory. It talks about the shape, the bulge, and the thickness and lack of inflammation. And they're key. So if your eyes are red and swollen, that's not keratoconus. Next one, there are different patterns. One's called keratoconus, one's called PMD, pellucid marginal degeneration. We were taught they were different diseases. They're not. They're different presentations of the same disease, and that is key. All right. The next thing is what they differ by the thickness, the thinning, and the pattern of the bulge. That's how they differ. And the fourth point there, we assess it by looking at you, using the microscope, and doing maps, computerized mapping. Point 5 is really important. We always were taught that these were a thinning disorder. They're not a thinning disorder, they're an ectatic disorder. Hold on to that word ectasia, I'm going to show it to you in the next slide. But they're all supposedly ectatic disorders. Next point, second last point there, keratoconus and keratoglobus are different entities. So same problem, but they present differently. That's all that means. And finally, the key one there at the bottom, true unilateral keratoconus doesn't exist, which means you don't get keratoconus in one eye, it's always in both. Pretty simple stuff. So what is ectasia? We talk about it as ectatic. This is where nomenclature is not always clear, perfect. Ectasia means a dilation of a hollow or tubular structure. The front of the eye is not hollow, nor is it tubular. And it's not dilated, which means stretched, like you have an aneurysm and the vessel stretches and then ruptures. It's just stretched. So it's not a vessel or a tube, it's just thinning and stretching of a tissue. So it doesn't really meet the definition of ectasia, but we use that word anyway. Back to the table. So keratoconus doesn't exist in one eye. Second point on the page. The best way to do it is tomography, which is one way of scanning the front of the eye. Third point, there is no adequate classification system, and there isn't. Fourth point, early keratoconus, there's some very subtle changes in the back part of the cornea. Fifth point, a secondary induced ectasia may be caused by a pure mechanical process, and that's key. Rubbing can induce the thinning, and to me that's the gold in keratoconus. Next point, central pachymetry, which means the thickness of the front of the cornea is the least reliable. We'll often measure the thickness and go, oh, you've got a thick cornea, therefore you don't have keratoconus. Wrong. I've seen quite advanced keratoconus in very thick corneas. Next point, the pathophysiology of keratoconus. It says, what drives the disease. It might be genetic, biochemistry problems, and there's biomechanical and environmental. And in my opinion, they are key. Biomechanical, rubbing, environmental, rubbing is an environmental factor. Final point there talks about topography to analyze it, which we all do. So that's the top one there. Second point, keratoconus can be present in a cornea of normal thickness, and that is key. You don't have to have a thin cornea to have keratoconus. The progression can be defined by some changes, but basically we look at difference map on topography, compare one, compare it with another, and if there's a change, you've got progression. And that can be associated with loss of vision, but not always. And finally, there are some conditions at the bottom, such as allergies, mechanical factors, and connective tissue disorders. Some people are born with stretchy tissues. You know those guys that can wrap their arms around, etc. If you don't have that, then it's not a causative factor. But if you do have that, it can predispose you for keratoconus. So this is all in Corneal Journal in 2015. Just to summarize, the cornea is always stretched and warped in keratoconus. It's always present in both eyes. The cornea is not always thinned. You can have keratoconus in normal or thick corneas. Keratoconus can progress, and your environmental mechanical factors are key. Rubbing. And that's keratoconus in a nutshell. I hope you found that useful. I'm Dr. Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery here in Sydney, and thank you for watching.